Chairman, ladies and gentlemen, first I would like to thank the organizers and especially Professor Neyi for inviting me here. First time in Tunis and extremely nice to be here. So, the outline of my talk, I will discuss today with you about oocyte demise, aging and fertility related to aging, family history and environmental factors, aging and ovarian endocrine function, a little bit about prediction of menopause, and then lastly something about possible therapies to treat ovarian aging. As you know, the follicle starts to develop after the 10th week of gestation, and around 24 weeks, almost all the oocytes are surrounded by granulosa cells. And the number of granulosa cells reach the maximum around the same time, about 24 weeks of gestation, and it's between 7 and 8 million. After that, there's a dramatic decrease in follicular and oocyte number, so that at puberty there's about 1 to 2 million left, and at puberty less than 500,000, and out of these 500,000 follicles, only 400 reach the ovulation stage, and that's the reason why women in general have about 400 menstrual cycles. At menopause, the number of oocytes is a few hundreds. And the decreasing follicular pool, and the reason why the number of follicles decreases so dramatically is due to programmed cell death apoptosis, which decreases the follicular pool already, as I said, mostly and mainly during fetal period. There are several apoptosis regulating genes. Most of them, the most important ones, they belong to BCL2 family, which contains both anti-apoptotic and pro-apoptotic genes, and BCL2 itself is the most known anti-apoptotic gene, while PAX is the most known pro-apoptotic gene. And the fate of the oocyte depends on the balance of the pro and anti-apoptotic genes. At the same time as the follicular number decreases, the number of poor quality oocytes increases. And this, of course, have consequences to the fertility. And we also know that at the same time, when the oocyte quality decreases, the number of spontaneous abortion increases. And we think that the fertility ends in general at the age of 42 years of age. Family history plays a major role here. Menopausal age is generally a very complex in origin, and we don't know if the same genes regulate normal menopausal age as also if the same genes are involved in the primary ovarian insufficiency. But most probably that's the case. They are the same genes. There are mutations in these genes, or the activation of certain genes which cause primary ovarian insufficiency, POI. And it's believed that the family transmission in boys is generally 30 to 40 years, percent. And variation in menopausal age can be explained at least by genetic variants by at least in 1/3 of the patients. Environmental factors are believed to play also a central role. There are certain, and also lifestyle factors, age of menarche, parity, age of first child, breastfeeding, diet, alcohol use, and so on. But none of these have been really defined but the almost only thing which is very well defined is smoking. Cigarette smoking decreases the menopausal age by 1 to 3 years, and this has been shown in several studies. But all in all, these environmental factors explain much less, anyway less than 10% of the cases, for instance, compared to the family history. And then a few words about prediction of ovarian aging and prediction of the age of menopause. We already heard a few presentations here on Thursday about this, so I just mentioned a few things which I think are important. At the same time as the follicular number decreases, actually the ovarian estrogen production remains still quite normal until a very late fertile age, and start to decrease only 1 to 2 years before menopause. And the follicular number goes down much earlier. And that's the reason why all these factors which regulate the production of estrogen synthesis, they behave the same way, and we can call them late markers of menopause. FSH, which is really important in regulating estrogen production, goes up, inhibins go down, and LH goes up about the same time, 2 to 3 years before menopause. So they are not a very good long-term predictors of menopausal age. And as we heard already on Thursday, anti-Müllerian hormone today is probably one of the best markers. It is secreted mainly from small and antral follicles. It is thought to modulate follicular recruitment from primordial cells to primary follicles, and it's also thought to inhibit FSH action in early follicle development, which is also the phase which is called FSH-independent follicular development. And most importantly, serum levels correlate well with the primordial follicle number, and that's the reason why it can be used for measuring ovarian reserve. AMH reaches its peak or maximum at around 20 to 22 years of age, and thereafter the decrease is relatively linear, which make it a good predictor of ovarian reserve, because we can in a way predict much better when the decrease is linear and it starts already early in life. Anti-Müllerian hormone levels correlate extremely well with the antral follicle count, and that's the reason why they both can be used and are probably the best markers at the moment. But there are a few occasions and where you have to consider the value, and the first is polycystic ovary syndrome or only polycystic ovaries. And the black dots here represent the individual values in patients with PCOS, and you can see that they are, in average, they are much higher than in healthy women at the same age. But these two lines get closer to each other while the women get closer to menopause. But this has to be taken into account when estimating ovarian reserve. And the other thing which has to be taken into account, which is very common, is the compound hormonal contraceptions, which decrease AMH levels by 40 to 50%. This is from our study where we gave combined hormonal contraception in 3 ways, pills, pads and ring, and all of them after using 9 weeks continuously decreased the levels very significantly. So, about anti-Müllerian hormone, it's very stable within and between the menstrual cycles, and basically you can measure it at which phase of the cycle. And, but still at the moment, there are no good reference values or and cut points, though the new assays have developed a lot and are much more reliable than the ones we used a few years ago. High AMH is always high. It really doesn't matter which method you use, but when we are measuring very low levels, then the assay is very critical, and that has been the cause of debate during the last few years. And should we measure AMH routinely? I myself don't do it always. I think in most cases intrafollicular count is still sufficient, but of course there are certain situations where you could use it, especially if there is already a suspicion of decreased ovarian reserve, or if there are already signs of primary ovarian insufficiency. And of course, when assessing fertility after ovarian surgery and cancer treatment. But always we have to remember that the patient, if the patient is using combined contraceptions, or if she has PCO. So to conclude, at this phase, AMH and intrafollicular count are the best measures of ovarian reserve. The stimulation test, what we used years ago, I think they don't have much value anymore. Probably we can still say that there is no superior factor to estimate ovarian reserve, but perhaps AMH. But one very important thing is that when you measure AMH, you should repeat the measurement first, and then you should interpret the result to the patient, and not say, after seeing first time that AMH is, for instance, 0.2 or 3, that she has decreased ovarian reserve, because you may have to change your words afterwards. Okay. Are there any ways that we could slow down the apoptosis process, or could we activate the ovarian reserve and activate those remaining follicles, or could we even grow new oocytes? Before going to those options, I just want to remind that at the moment we don't know exactly if those patients which are now marked here with the red line, and they have already during the fetal period low number of oocytes, if they enter menopause earlier than those marked by green line, which had the highest values. This probably is the case, at least to some extent, but we don't know. And it may well be like this, that although the red line has the lowest reserve, the anti-apoptotic activity in these women may be lower, and the apoptotic demise of follicles may be lower. Or those marked with the green line, they may have more active pro-apoptotic genes. So this all depends on the activation of different genes. But as said, probably it's like this, probably it's not like this, but it may be somewhere in between. So then, of course, we have a possibility to give gene therapy and to introduce therapeutically important genes, for instance, anti-apoptotic genes into the somatic cells. It is general consensus still at the moment that gene transfer should be avoided to germ cells. But of course, then the important question is how to target the gene therapy in the ovary or in the follicles. Oh, here are a few samples. You could inject the gene to the ovarian artery or give intraovarian injection, But of course, you can't still be sure that your therapy is only targeted to the ovary. It can still be targeted to other organs as well. And this kind of treatment is not very obvious at the moment. And moreover, it's unclear if the oocytes prevented from executing apoptosis would retain full functional competence, and we may even cause aneuploidy, or most importantly, we could even induce cancer by inhibiting apoptotic process, which is the main mechanism to avoid cancer development. Okay, now about 10 years ago started the discussion, are there oocyte-producing stem cells in human? Actually, this discussion started for experiments in rats, and Jonathan Tilley was the first one who really proposed that there are stem cells. I think at that time not very many believed in that, but now probably the opinion has changed, at least to some extent, and human orgonia from stem cells have been actually isolated. The second option is, which is to my understanding at the moment most promising, is the activation of primordial and secondary follicles. Unfortunately, I can't use the pointer because it's, yeah, you don't see it. But there are two ways to do this. We can activate the primordial follicle recruitment to primary follicles by stimulating certain signal pathways. Here they are called AKT and mTOR. The other one is protein kinase B, and the other one is serine threonine kinase. So by activating these pathways, we can stimulate and induce the primordial follicles for growth. And the other option is to affect hyposignaling. Hyposignaling is kind of inhibitory mechanism which inhibits the cell growth in general. And by disrupting this signal, for instance, using mechanical ovarian fragmentation is a way to do that. So we can use these two ways, and this is what has been done actually. We have a patient with primary ovarian insufficiency. The ovaries can be removed and fragmented and frozen, and then when the fertility becomes actual, then they can be thawed, and the fragmentation of the ovaries already induces the growth of the follicles. And then we can also use these stimulators to stimulate the transformation of primordial follicles to the primary follicles. And then these cups or pieces of ovaries can be transplanted back to the body, and then using in vitro maturation or normal ovarian stimulation protocol, we can get embryos and of course get a pregnancy. And actually the first baby using this technique was born in Japan already 2013. And third option is to produce and grow human gametes in vitro. This has been done already in mouse, using mouse stem cells, and they have been able to be grown and also fertilized. So this probably will be one option in the future, but so far the human experiments are lacking. So we have several options. So to conclude, the present concept of biological clock may change. There are possibilities to prevent oocyte and follicular demise using gene therapy and apoptosis modulators, but as said, that may be quite difficult because of the targeting process. Or we can produce oocytes from stem cells, or the third option is to activate the few remaining primary follicles, especially in patients with POI. So, thank you very much.